All right, I think we're ready.
All right, thank you very much. We are going to go ahead and call to order at 12 noon. Shelley, if we can do roll call, please.
All right, Dan Spate,
Here.
Frank Walter,
Here.
Gail Bradley,
Present.
Glynis Zeman, Jason Johnson,
Here.
Jonathan Madam, I know, where'd he go? You're still muted.
I'm having some mute on-off problems here, but I am physically here.
All right, thank you. Joshua Gaither, we'll be expecting him in a few minutes. Julie Augenstein is absent. Kevin Foster. Michelle Preston.
Present on the phone.
And Ryan Page.
Here.
All right, we have quorum.
Excellent. Thank you very much, Shelley. Just a reminder, some Google Meet announcements. If you hover your mouse over the bottom part of your screen, you'll see the buttons to turn your video on and off, to unmute and mute yourself, as well as to hang up. All attendees are advised that this public meeting is being recorded and will be posted on the ADHS website. So anything said verbally, viewed via webcam, or typed in the chat box will become part of the recording that is posted on the web. Please mute yourself when not speaking. If attending by phone only and you would like to speak, press *6 to unmute yourself. Shelley will be displaying the materials to the group, so there's no need to present your screen or share your screen. Shelley, Julia, and Allison are monitoring the chat box for any questions. And because we're doing this online, please identify your name before you comment so that we can capture your comments for the record. Thank you very much. Attendance report is in your packet. We are doing pretty well. We do have a vacancy still on the committee. I know there have been applicants for this position. The Governor's Board and Commissions is catching up on those, so we will hopefully have that filled shortly. 2021 meeting schedule, that is in your packet as well. We have tried to vet this with any of the big national conferences. We do not believe that there's any conflicts on the schedule. This did go to EMS Council and STAB, but if there's any conflicts this group sees, please let us know. Otherwise, this will be the 2021 meeting schedule. All right, thank you. So I know everyone in this room, I'm sure, is aware, but unfortunately, we are going to have to say goodbye to Terry. He is leaving us and will be going to Montana. His last day with the Bureau will be September 25th. Terry's been here over 14 years and has been an integral part of our entire EMS and trauma system in Arizona. And I think really is going to be missed by all of us here in the Bureau and amongst the state. So he's going there just in time for the snow. He's leaving record heat here in Phoenix, and I think they've gotten snow there already in Montana. In typical COVID style, the best send-off we can give him was dragging a couple of us in yesterday to take a picture and give him a plaque, which you guys are seeing. We removed our masks very briefly to take the picture, and then we quickly put them back on. But again, not enough words to kind of say we will miss Terry, and unfortunately, this is the most we can do in terms of a send-off for him. But I will let Terry talk about his transition, but just wanted to say a big thank you to Terry for all of his work over the last 14 plus years in Arizona here for EMS.
You're on mute, Terry.
I was giving a great speech. It's a bittersweet move, one that we don't take lightly. I'm reminded of the fact that the past 8 months have been some of the most challenging of the past 14 years, and the Arizona EMS and trauma system that I've had the pleasure of working with for a long time now, along with a great staff here at the Bureau, have been able to respond appropriately. And I think that Arizona's EMS community medical direction community and trauma community is nimble, responsive, and dedicated to doing good work. And so it's been my pleasure to serve. In discussing the process for finding a replacement for me with my boss, Jessica Rigler, Assistant Director Rigler, she wanted to make certain that we advertise internally here at ADHS around the state and nationally. And that process was begun. And I anticipate that there will be a first round of interviews sometime in early to mid-October. And it's not uncommon for the process to take about 45 days once interviews begin until someone is actually hired. So I think that hopefully by mid to late November, there'll be a bureau chief in position. During that time, obviously, Dr. Bradley will be here. Ben will be here for the services section folks, but Ethan will be acting as the acting bureau chief. Ethan's been in the deputy bureau chief role for 5 or 6 years and knows this bureau like the back of his hand. So don't feel free to reach out to any of our staff to seek assistance. Dr. Bradley, any questions on that process? If not, I'll just go ahead and give a brief rules update, Dr. Bradley. Many of you know that we have been, we opened up a lot of different rules that required updating. And because the way our rules are written, a rule in one section frequently has related rules in other sections. And so we actually have a very large rule package open. The majority of the work has already been completed on Article 7 and Article 8, the air ambulance. And then a good portion of the work has been completed on Article, I think that's 10, ground ambulance and vehicle registration. We're now heavy into the work on Article 9, which is the rules relating to the certificate of necessity process for ground ambulance services. A year ago, just in November of last year, we began with having 2 broadly distributed requests to the stakeholder community in Arizona to provide comments and feedback to the department on the existing Article 9 rules. We got a lot of comments and have been working internally to create a draft based on those comments that was released 2 weeks ago. That draft represents the Arizona stakeholder community, and it has been posted and is up for comment through October 4th. There is a public opportunity to provide written comments to the department, and if you've not been involved in rule writing before, we must respond to written comments. And so that's the preferred way for us to seek to get input from the field. On October 14th, we will hold a virtual public meeting to discuss the draft rules and the comments that we have received. And then we will begin an iterative process where we receive comments, we revise the rules, and that process goes along until we get to a draft, which is called a final draft. And then we start the formal rulemaking process, which ends with a trip to the Governor's Regulatory Review Board for final approval. And I anticipate that that will be sometime in 2022. On that October 14th meeting, we anticipate that there will be a couple of hundred people who are likely want to listen into that process, but it's going to be a real challenge for folks to make verbal comments during that. So we'll have the chat box open and we'll have several people monitoring chats. And then if you are part of an organization, it would be helpful for us if you always make your written comments to us. We want that from everybody. But for the verbal comments, it would be helpful if you can work to identify a spokesperson that can carry a similar message. I think that's all I have to say on the rural work. Any questions on our rural activities? All right, Dr. Bradley, that is the end of my my comments.
All right, thank you very much. Next up to Ben Fisher for service sections update.
Thank you. I have a couple things I'll run through really quickly. We have started compiling some COVID data that is of interest to our stakeholders about the increase in deaths and cardiac arrests over the COVID period. We are going to try and make that report available as soon as we are able to. We have a couple more things to kind of sort out, but we hope to publish that here very shortly. The STAB report was voted on this morning and will head to the director for approval and will be on our website shortly as soon as the director signs the approval. The services section has additional dashboards that are on our website. If you navigate to the Bureau's website and look on the left-hand side for the data and quality assurance section, there is now a tab for data visualizations, and as we make more Tableau dashboards, they'll be available there. And we have a couple more that we're waiting for approval to post. So hopefully we will continue to make more of those, including updating the annual trauma STAB data dashboard. The trauma registry AZ Peers link is now active for trauma registrars to be able to receive EMS data directly into their trauma registry. They approve whether or not they want to import that information. It does require an exact match. So if the name and date of birth don't match exactly, it won't appear. We're talking about ways to kind of improve that or make options available. But obviously we have to be pretty conservative. We also have an intern who is producing a survey that will be used for our needs assessment. So for agency medical directors, we only need one response per EMS agency, but that information is extremely helpful to us. So if you're able to have your agencies fill that out, we would certainly appreciate it. And then finally, the very last item is we are discussing and will take some alternatives to EMS Council in January, kind of changing the Cactus programs. We would end the Cactus program the way it exists today and discuss having some sort of alternative, because we know that right now the feedback is not fast enough for agencies to do useful quality assurance. And so we need something that is a little more timely. Right now it's taking 6, sometimes 9 months for us to be able to produce this. And we continually run into IT issues that have really challenged us, and my team has done some really great work to try and overcome them, but it has really slowed us down, and so we're just not able to produce these reports as fast as we would like to, and so it's time for us to kind of explore some alternatives because of that. That is the end of all I have. I'm happy to answer questions about any of those items. Otherwise, please feel free to comment on the STAB report or the dashboards. We certainly welcome feedback on those as well.
Thank you. And I just wanted to emphasize Ben's report regarding the dashboards. There's an amazing amount of work that went into producing these dashboards. They really have excellent data, both regards to EMS and trauma. So if you're looking for something to do a little time, just go to the Bureau's website on the left side, and you can scroll down and then click on the dashboard. So just wanted to plug that as well. They really are very useful. We are going to move to the standing committee reports. I don't know. I think Dr. Gaither is tasked with the first 2 reports. I'm not sure if he is able to join us on the phone yet. I know he's in an area doing training with some poor reception. Dr. Gaither, are you on the phone? What we might do is go ahead and move down to discussion and action items and then come back to the standing committee report, if that's okay with this group.
Fine.
So thank you. We'll start with the discussion and action items. If I can get a motion to discuss, amend, and approve MDC meeting minutes.
Maytem, so move.
Second.
Jason, second.
All right, thank you. So Dr. Gaither just said he's here but muted, but we will finish this item and then go back to the report. All right, so we have a first and a second. Meeting minutes are attached, and we can take a minute to review those and see if there's any amendments needed. All right, hearing no amendments, all those in favor, what we will do, we have done for a kind of an online vote, is we'll ask for ayes and nays. If there's any nays, we'll do an individual roll call. All those in favor of approving the minutes as displayed, please say aye.
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 Any opposed, say nay. Any abstentions? Thank you. Meeting minutes are approved. We will go back up to the standing committee reports. Dr. Gaither, I think you're up for TEPI, Education, and PMD.
Okay, hopefully you can hear me now. Is that better?
Yes, we can. Thank you.
All right, I apologize for the technical difficulties. So let's start out with TEPI. The brief report from TEPI was that we did review the sequence for discretionary bureau reports. We did add in a request that the Bureau consider tracking of COVID-19 administrative guideline changes to patient care. Examples of this were decreases in BiPAP use, decrease in nebulizer use, and increases in the rates of nasal cannula use. So that was added to the list of suggested or possible reports to be published at the discretion of the Bureau. We also discussed the Cactus data set as Ben Fisher outlined previously. Additionally, we did briefly discuss the bylaws. The main concern from the committee was that we balance representation at the TEPI committee from all regions of the state. That was it for the TEPI meeting. The next meeting was the education meeting. At this committee meeting, the group approved the sepsis educational PowerPoint plan, the brewery training PowerPoint, as well as the chest compression training PowerPoint. That was it for the education committee. For PMD, we discussed scope of practice changes extensively, which are on the agenda for this meeting coming up. We did defer to the educational committee to develop a bridge curriculum for any scope of practice changes that are eventually approved through Medical Direction Commission and EMS Council. We did approve the addition of high flow nasal cannula to the paramedic scope of practice. And again, for this group, discussed the bylaws, updates, and considered adding the position for a toxicologist to that committee. That's it for those committee reports.
All right, thank you very much. Julia, PACES report.
At the PACES meeting, we discussed the results of this year's National EMS data collection. That survey will go out again this upcoming January through March. We also discussed the National Pediatric Readiness Assessment that was previously scheduled for this year. Again, will take place next year. So promotional materials for that will be distributed in the near future. We also discussed and approved the development of a work group for children and youth with special healthcare needs. So we have had one meeting for that and hope to produce some materials in the future. And we continue to work on the Safe Sleep project and hope to be able to finish with that soon. End of report.
Thank you, Julia. All right, we will move back to discussion and action items. Next discussion and action item is recommending that the department seek authority to move scope of practice out of rule. If I can get a motion to discuss.
Make that motion.
Thank you, Dr. Madem. Can I get a second, please?
Walters, second.
Thank you, Dr. Walters. All right, so I will give a little bit of background for those of you that were not on EMS Council. One of the areas that we've recognized is as there's been a rule writing moratorium kind of intermittently over the past at least 10 years, we periodically have things that get updated, such as scope of practice, but we're not able to actually update that in our rules. And one of the things we recognized that this was also affecting were the drug tables. So about a year and a half ago, we moved the drug tables out of rule and put it through a process where this committee made the final recommendation, which went to the director of ADHS for final approval and posting. We found that that's been a much more timely and proactive process. It's allowed still for stakeholder input and has kind of multiple checks and balances in place, but overwhelmingly it's been very well received. We made the proposal to PMD EMS Council and now to this group to move this out of rule. The process, if this is approved by MDC, would be that any scope of practice updates would go through PMD first. Recommendations from PMD would go to EMS Council and MDC. If EMS Council and MDC approve those changes, the Bureau would put together a letter with kind of explanation of changes made with recommendations that would go to the Director for final approval. EMS Council did approve moving this out of rule, so I just wanted to give a little bit of background, and then I will open up for discussion now. Thank you.
Gail, you might just give, for those that weren't at EMS Council, you might just give a few of the comments that did come up about there is slight different ways of accountability between rule versus this, and that's since it's scope of practice, which is ultimately physician driven and accountable and responsible. I think it is worth reminding most of us are not very savvy to some of the technical differences, but there is a difference just to make sure we know what we're approving, the implications of what we're improving. And I am, by the way, I'm in favor, and I think it passed unanimously at council. Am I still on, Gail?
Sorry, I was not. I was talking, but still on mute.
Oh, you like Terry, you gave the best speech of your life. Unfortunately, you've forgotten it already.
I did, yes. 3 hours and 22 minutes in for today, I pulled off for the first time, so that's a win, I guess. So yes, similar to the drug tables, one of the things that we wanted to ensure that I don't think I was as clear in making the point in EMS Council initially is that if this does get approved by MDC, rule would still reference scope of practice, so that would still be in rule. The difference would be that each individual line kind of delineated in detail would not be in rule the way it currently is. So I think just to kind of make sure, I think there was some concern that once we talked it out, the group was comfortable with that, yes, we still do refer to scope of practice in rule, we just wouldn't necessarily refer to each individual line. Any further discussion or input on that piece of it?
Dr. Bradley, this is Terry. I'd like to just share a little bit about the functional difference between having the table in rule versus having the table outside of rule but approved by the EMS Council and MDC, if I could. Right now, when there is a request to amend the scope of practice, it comes up through PMD, typically goes to MDC, and MDC will then vote to make a recommendation to the Director. The Director would receive that recommendation and then apply to the Governor's office for the ability to open up the rules and move the rule package forward. And during these extended periods of time where we've had a rule moratorium, what we've identified is that we have a backlog of scope of practice changes that we haven't been able to move forward into and make effective, even though they've been approved by EMS Council and the Director, MDC and the Director. This change would not change would not change the role of MDC or EMS Council at all. In fact, I think would in some ways strengthen it, because they would still make a recommendation to the Director. Dr. Bradley and the Bureau Chief would then create a transmittal letter which reflects on the intent of EMS Council and MDC. That then would be sent to the Director, who then could authorize the change in the table. A question came up during EMS Council about whether or not this circumvented statute, and I wanted to just confirm that it does not. we worked with our Office of Administrative Rules to make certain that the process we're describing would be fully consistent with the statute, and I think end up reflecting the needs of the EMS and trauma community quicker and more effectively. And so that was the reason. And I have gone to the administration of the department to seek approval for this, and they gave their full support.
Thank you, Terry, for that explanation. Any further discussion?
Yeah, Dan, again, I'd just like to say this, some of us on this commission recall basically almost 2 years where we were making motions and all this kind of stuff, and at the end we'd say, okay, that was great work, and now we're not sure it can actually be changed. So this kind of, to me, is the fruition of finally becoming efficient and facile on things like this.
Thank you, Dan. Any further discussion? All right, we will go ahead and take a vote then. All those in favor of recommending that the department seek authority to move scope of practice out of rules, please say aye.
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 Any opposed, say nay. Any abstentions? All right, motion has passed. Thank you very much. We'll still take the next item as an action item, and I will give a little explanation as we start. Can I get a motion to discuss, amend, and approve PMD approved updates to table 5.1 scope of practice?
Motion, Mayton.
Thank you, Dr. Madam.
Second.
Can I get a second?
Walter.
Thank you very much. All right, so just to give a little bit of background on this, we did discuss this quite a bit. PMD took a really extensive dive into looking at the national scope of practice, kind of looking at some of the changes. We recognized that there was a number of items in Arizona scope of practice that were truly out of date and had been removed from national scope, but yet we're still in Arizona scope of practice. Some of those summary of changes that are no longer in national scope are things like umbilical initiation, Select maneuver, also things, the terminology patient assisted with medications that was removed from national scope with specific explanation that it was really confusing to the EMCT and to the educator as what it meant when we said patient assisted. Is the EMCT really assisting the patient in administering their IM injection, or is the EMCT actually giving it? So that terminology has been removed from national scope. Some of the changes were really kind of grammatical things like changing orotracheal intubation to endotracheal intubation. We did have a number of STRs for EMTIs. Some of those have been removed. We did a look to see how many certified EMTIs we have in Arizona currently. There are 13 EMTIs in Arizona. We have a little over 22,000 EMCTs. We do not know how many of those EMTIs are still actively practicing or at what level they are practicing. There's also items like Crike was listed 3 different ways in the Arizona format that was in the national scope, just a single version. So that was kind of streamlined as well. And then we added an Arizona scope section for items that are not necessarily in national scope, but still felt to be recommended in Arizona. One of the items I do want to debate, because I think there's quite a bit of discussion at PMD, was in regards to nasal and pharyngeal swabs as well as immunizations. Obviously, in times of COVID, there's quite a bit of discussion about that, so we will get to that piece. And to Dr. Spade's point, a couple years ago, this group approved IM epinephrine for anaphylaxis for EMTs. We developed an educational curriculum was put forward. We approved that as well. And we realized after the fact we put the cart before the horse because scope of practice did not allow that. So that's kind of a summary of some of the changes. When this went to EMS Council, so EMS Council did vote to move scope of practice out of rule. There were 2 items which I think were the sticking points, which I wanted to point out. They decided to table approving scope of practice. They wanted to look at CPAP at the EMT level, whether there should be a STR versus a check mark. This was something actually that was discussed quite a bit at PMD, as also just keeping that as an STR. And then the other piece is, if you look at page 3, medical director approved medications, there is some concern that that section may be in conflict with statute in some areas. So the recommendation from EMS Council was to take those specific sections back to PMD for review. What I would like, since PMD did spend quite a bit of time, is to not take the whole packet back, but I wanted to see if there's other sections in this document that MDC is not comfortable with, or they'd like to send back to PMD for review. And that way we can hopefully have something brought forward in the January meeting to EMS Council and MDC.
I'm just going to verbally share that if your phone is on mute, you might need to hit *6 to unmute your phone.
Thank you, Shelley. So just for discussion, there were some items that were debated quite a bit, and they're not in the national scope, but we have elected to keep those. That's why they're STRs in Arizona for EMTs. This included IV access. Several medical directors stated that they had a large number of personnel that did that, and so we certainly don't want to create a situation where there's any, we're reducing access to care. So that was kept on page 4 under skill IV initiation as a STR.
I had a question about the terminology spinal immobilization, which appears a few times throughout, and changing that to the newer spinal motion restriction. And want to get others' perspective on that.
Yes, so there's a kind of a draft version that has a bunch of different color codes on that, and then the clean version, which has it all updated. So we updated that to meet the current terminology. So all spinal mobilization. So if you see the screen right now on page 2, all of those are now kind of the more up-to-date terminology, because you are correct, it was quite dated.
Okay, thanks. I just saw it flash by again
Yes.
on the colored version. Thank you.
Yeah, absolutely. No, definitely, those are some of the changes we recognize that were pretty out of date, even though it's been several years since we've made some of that transition in Arizona.
Thank you.
So I'll kind of just briefly talk about a few that we did discuss. One of the things we recognize in Arizona, a lot of agencies have EMTs perform supraglottic airways. That is still the national scope, is not approved for EMTs, so it's going to remain a recommended STR. Same one for end-tidal CO2 monitoring and interpretation. The national scope, this is not an EMT. They did mention that in the future this may be added. I think with the EPIC study, most of Arizona's EMTs kind of were educated on end-tidal CO2 monitoring and interpretation. And so I think the STR is probably appropriate for that. Most of the other changes are pretty reasonable. The one, again, I did want to bring attention at the very bottom of page 4, under Arizona specific, just for this group to discuss, but I think there was some really good varying inputs on this, is about collecting nasal and pharyngeal swabs for diagnostic testing. That is not in the national scope. Obviously, with COVID, that is up for discussion. And so wanted to bring that forward for this group to really discuss as well. That, along with immunizations, which it'll take me a second, but I will find out which page that's on here. Immunizations is page 3. Any thoughts
Gail,
or discussion?
can you or anybody else, maybe Josh might be closest to this, what's the driving force behind the need for EMTs to do immunization and or nasal swabs? I'm not talking about mean, obviously, you know, you add a few people who can do public health stuff, but the reason I have concerns is it's just another one of those potential distractions driven by city councils and all kinds of people to get EMS to have greater and greater loads. And ironically, a time when in cardiac arrest, brain injury, maybe in sepsis, certainly in multiple other settings, the time sensitivity of response and being available and workload issues and all those kind of stuff are, in many ways, should be pressing more focus on time sensitive issues. This obviously creates the potential for us becoming a clinic and then also sometimes responding. You see what I mean? So any comments on that? And like I said, Josh, I bet you've probably been involved in that. So I'd be interested in some, what's the push for this? Other than the obvious, having more people who can do this stuff, which has implications certainly for, certainly has implications.
Thank you, Dan. A little bit of background noise there, but I think, yes, we did capture most of what you're saying. I know your points, I think, are what Josh spoke about at PMD. So that's why I wanted this group to really address those two items with some recommendations to go back to PMD to ultimately come to these committees. So I don't know, Josh, if you're able to speak to that.
Sorry, Dr. Bradley, can you hear me now?
Yes, thank you.
So I agree with what Dan kind of brought up. I see the need for this for any pandemic or public health emergency, whether it's the current COVID situation or hepatitis outbreak. Clearly using our EMS providers as a force multiplier to provide vaccines is a valuable and important tool. That said, I don't know that this is something that should be broadly put within the scope of practice. So I think my proposal for this would really be to maybe modify this slightly to say administration of vaccinations under public health emergencies or some caveat like that.
Would you also suggest then diagnostic testing during public health emergencies, Josh, or just leave it to vaccination or immunization?
I think for this item, we would limit this to vaccination. I think diagnostic testing is very, very broad. I certainly wouldn't want to put that in for, I would be hesitant to put that in as a broad, any diagnostic test.
Agreed. Thanks for refining that. I was thinking more about the nasal or pharyngeal swabs. Also, there are also saliva tests. I was just on a national meeting yesterday with Washington, D.C., and they're having their citizens go to their fire stations for diagnostic testing, things like that. Nasopharyngeal swabs, just because they're in the communities and a trusted entity. And in Champaign-Urbana, they're doing it through their university rather than their fire department, and they're using saliva.
I think I would defer.
Oh, I was just going to say, this is Dr. Vogel saying, I mean, we're talking with Tohono O'odham right now about using our medics, but not EMTs, potentially to administer flu vaccines and COVID vaccines if that comes available. You know, I think in that case, since it's so rural, you know, that will be helpful in that situation. But, you know, I don't know about the COVID swabbing itself with the station and everything like that. If you can. Do
you think next week when we do the event stuff, I might be able to record some of it so we get new hires and stuff?
Sorry, we're getting some background noise. I don't know if someone's intending to speak there. Thank you. Just for clarification,
This is Dr. Stites. Sorry, I was trying to speak real quick.
Go ahead.
I just wanted to put this out. It seems like there's an unlimited number of circumstances and areas in which this could be incredibly helpful. That maybe a blanket policy saying yes or no is not appropriate, and that there would be a way to leave it up to the medical directors to determine in those particular cases. I think the question then would be, is this something that's safe for this level of practitioner to perform? And if the answer to that is yes during certain times, then I think that it's yes all the time. And then it can be determined by the medical directors as to when and where that is the most appropriate. And a broad appeal is probably not the best way to approach it.
Dr. Bradley?
Yes.
Excuse me, it's Brian. There's already a separate rule on immunizations. I want to say it's our 925-505. That's a separate, it's separate from this anyway, which allows for immunization. So if you were to try to proceed to limit this, then you are going to have to figure out a way to deal with that rule. It is exempt rulemaking, so it wouldn't have to go through the regular rulemaking process, but it is a sideline, perhaps, discussion to this since it already exists.
Yes, I think there has been quite a bit of discussion regarding kind of the rule waivers that have been put out. And so I think to Brian's point, immunizations are covered in a couple different places. Currently, paramedics in Arizona are able to administer immunizations as long as it's on the CDC list of approved immunizations that's on our drug table, table 1. And I'm trying to find, I know it is buried somewhere on the original scope of practice. My apologies, but I can't reference exactly what line it's on. But that is allowed. So the question is kind of twofold. The one I think probably is whether or not this group wants to keep the STR on there for nasal/pharyngeal swab for diagnostic testing. Would you make that recommendation to keep that, to go back to PMD, or remove that? And then the second discussion piece would be the immunizations at other levels such as EMT.
Gail, this is Dan. Let me make my concerns real, and I think this is probably along the way, probably the group that is most has the 100,000 foot view from both medical care and safety, but also systems perspective. I had a conversation with a fire chief, one of my fire chiefs that I'm the medical director for, about 6 or 8 years ago, that was developing community paramedicine, and had developed the entire program. Finally, I got to see it after all that. And I asked a simple question: what will happen if the medic unit is out doing a finger stick for a follow-up diabetes discharge from the hospital, and down the street there's a cardiac arrest? And his answer was, well, they'll be out of service because they're doing the diabetic follow-up, so somebody else will have to come. In that kind of setting, the next closest unit responds typically from about 8 miles away. And I do have overarching concerns out there. If the perspective is, can EMTs do this medical procedure, or in this case, diagnostic question of being able to get the specimen for diagnostic stuff. There's almost an unlimited number of things that we could teach them to do. And I have concerns that the individual medical director gets pressured by the county supervisor, by all those kind of things, and or even sometimes the fire chief. So the idea of always leaving it to the individual medical director, I don't think they have the perspective of this group. And so I do have concern about an ever ballooning scope of practice into public health initiatives, which we have a gigantic system for, and the EMS gets distracted. And just like in EPIC, in the second half of the 3 years after EPIC training, we lost half of the survival benefit in the second half. But what we got in exchange was a great Ebola preparedness plan and training. And we've, to this day, still never transported an Ebola patient, not one, in Arizona. So I do have concerns about can they do it? Can they do it safely? Sure. And I don't have a specific issue going on right now, but I wouldn't be surprised if there are plenty of medical directors who are being arm twisted into, well, they can do it, so we want to start running a clinic. And there's so many pressures to do that. It takes away from the primary response. So this isn't theoretical. There was a situation where a fire chief, to make the community happy, was literally going to have people out of service down the street from cardiac arrest because they were doing a finger stick. So that's my concern.
So it sounds like kind of the feeling from this group is that the recommendation regarding swabs for diagnostic testing, that we consider removing that recommendation for it to be a STR. Currently, immunizations are still in scope for paramedics, and it sounds like pretty much uniformly the group's view is to not have it added for EMTs. Is that a decent summary?
Yes. The only real critical diagnostic testing that pre-hospital providers do is glucometer.
I wanted to see this. It's my little business. I have a little office.
I'm sorry, someone is not on mute there talking about an office. Thank you.
I agree. I don't think the nasopharyngeal swabs are time critical. The only thing, and anybody can correct me, but my perspective is the only diagnostic testing that's time critical in the field is glucometer, oxygen, and CO2, and EKG and rhythm strip. And those are time critical, but I don't see nasopharyngeal swabs as time critical. And I do support immunizations. If including EMT.
This is Jason, and I feel the same. Yeah, because I don't think that we really need the swabs, but definitely it would help with some of our agencies that are BLS only or BLS on some days if they could do the immunization if and when they come out.
Yeah, Maytem, I certainly agree.
And I am making us go through a lot of discussion because I think ultimately we're going to vote to table this, hopefully, but I did want to try to capture the feedback from this group. So the hope would be that any feedback on the scope of practice we take back to PMD in November. PMD will take another stab at specifically the sections that EMS Council and MDC would like reviewed, and then we would propose an updated scope of practice at the January EMS Council and MDC meeting. So I appreciate you guys doing a lot of discussion for what ultimately won't be an official vote today, but I think it certainly helps the process to kind of talk through these things now. Are there any other items that are on here that we have not covered that the group would like to talk through? And I apologize, having done this twice in a row, I have to try to remember what we talked about in the two separate meetings. So please feel free to speak up if there's any specific items you would like us to go over.
And just a friendly reminder about the *6 if you're having a telephone in your hand to unmute.
Thank you, Shelley.
I did have a question about this inhaled monitor patient administered nitrous oxide.
Yes, so that is kind of twofold. That has for some reason been in the Arizona scope of practice. We aren't aware necessarily. We did talk about that at PMD if anyone in the state was doing it. I believe, Jason, I may be misquoting you, but did you say one of your agencies used to or is doing that? Is that correct?
One of them used to use it, and it was the ones that cover the power plant. They kept some if there was ever a mass casualty kind of situation, but I haven't signed any drug reorders on that in probably at least 4 or 5 years.
I would suggest removing it.
Now, Frank, the problem with removing it is, you know, it really does have one great purpose. It's really good for medical people to abuse. So I don't know. Its number one usage right now seems to be medical abuse.
Yeah, thanks for that, Dr. Spate. That's great.
That was one of my concerns about. Yeah. Thank you, Dan.
No, I think I definitely thank you very much for bringing that forward, Frank. I think those are the types of the feedbacks where we look at something that have just been in scope that we can try to identify to take back. So thank you for identifying that.
Gail, this is Rebecca. May I add something? I know I'm not part of this committee, but I've got experience with nitrous oxide with my agency.
Yes, please, Rebecca.
We used nitrous oxide for a number of years. We finally eliminated it in the early 2000s, and there were two primary reasons. Number one, we were dealing with a predominantly geriatric age group, and we had extreme difficulty getting them to be compliant with using the mask and holding it and inhaling it. And when we're on scene with a potential hip fracture and we're trying to eliminate pain, it was taking 20, 30 minutes just to try to get them to use nitrous properly. So the other analgesics we have available are much quicker and easier to administer. There's not issues with compliance. One other factor why our agency eliminated it was because of the cost of the hydrostatic pressure testing for the cylinders. That has to be done periodically. And whether you as your agency eats that cost or you pay a vendor to do it, it becomes quite pricey. And then, of course, to echo what the other physician said, the highest thing we saw were everybody wanting to get in line every morning and test it out to make sure it worked. So yes, medical personnel abuse is a problem. Our agency was able to save significant money by eliminating it, and we actually improved our on-scene times and had greater patient satisfaction scores with pain management once we stopped trying to mess around with nitrous. Just an anecdotal information to share with you from an agency that had it. Thank you.
Thank you, Rebecca.
Dr. Bradley, this is Matt Shaw. May I add something?
Yes, please, Matt.
Thanks. There is, I guess I would, while I agree with both what everyone's been saying about the nitrous oxide, there is another drug that is currently making its rounds through the FDA approval process, which is methoxyflurane, which is marketed as Penthrox. This is a common inhaled drug that's used in Europe, Australia, the Middle East, and this is a non-opiate pain relieving drug. With the opiate crisis that's in the United States, it might be worth leaving, assisted inhaled medications on the list, waiting, a year or two until this makes it through the process, and then we can determine whether or not it would be worth adding to the scope. But I feel like we're always looking for non-opiate medications that work. I have previous experience using this medication when I worked overseas. It's very effective. And so I guess it's easy to leave something in. It's very difficult to put it back in if we take it out. Thank you.
Thank you, Dr. Walter. I will see if you have any thoughts on that, your expertise.
This is Dan. I think that at the MDC level, it should be very hard to get things in and easy to remove things. So I don't like the idea of keeping something open, if you will, for a potential future where it's going to have an entire need for looking at the studies, looking at the use. etc. So I say close it down now. We can always re-up.
Dr. Bradley?
Yes.
It's Brian again. Under medication administration routes is inhaled. That's inhaled. I think the reason this is addressed in the separate section is because it's specifically for nitrous, and that's under medical director approved medications. So there, it doesn't really, if we don't want it to address nitrous, we already have inhaled in the routes section, and then it would be very easy to add to table 1 drug box list later on.
Also, just to address the concern about maybe precluding the possibility of methoxyfluorine in the future, this row says very specifically not e.g., for example, nitrous oxide. It says i.e., that is nitrous oxide. So this is exclusively for nitrous oxide. And if we eliminate this, it wouldn't preclude us for PMD bringing forward methoxyfluorine if they think it's a wise move in the future.
Thank you. Any other items this group would like to send back to PMD to review? All right, hearing no others, I think we are going to actually ask now for a motion to table and send this back to PMD for further recommendation.
Motion to table, Maytem.
Thank you, Dr. Batum.
Walter, second.
Thank you, Dr. Walters. All right, all those in favor of tabling this, pending further input from PMD, say aye.
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 All those opposed say nay. Any abstentions? All right, the motion is tabled with recommendations to go back to PMD. Thank you again to everyone who participated. I know that was a little bit of an academic process since we knew that it was not going to go forward right now, but we did want to make sure that the recommendations from MDC go back to PMD for review. So thank you for going through that with us. Last discussion and action item, if I can get a motion to discuss and amend and approve updates to the bylaws.
Motion to discuss.
Thank you. Sorry, who was the motion from?
I apologize. It's Maytem.
Thank you, Dr. Madam. Didn't sound like you for a second.
Mic problems.
All right, can I get a second, please?
Walter, second.
Thank you. All right, so the bylaws need to get updated every 3 years, so this we are due to update by the end of 2020. Dr. Johnson very kindly led a subgroup, and so I will let him speak to that. And we have feedback from both his group, which had members from the 3 statutory committees, as well as the Bureau. Dr. Johnson.
All right, thanks. Can you hear me okay?
Yes, thank you.
Okay, thanks. All right, so you guys can see it. It's at the end of your packet, about the last 3-4 pages. And the big things that we changed are highlighted. Some of the things that were added in were things such as adding in electronic media, because now that we're using everything on Zoom or Skype or Google Meet, those type of things. We changed or eliminated things such as where special meetings and or telephone meetings, we just got rid of that altogether, and then clarified some of the specifics that were in there as far as what was appointed by the governor, what was for MDC, putting in things specific to the Bureau, making sure the A.R.S. things were required, and in the first part, I guess to say, basically just kind of cleaning up the purpose and getting rid of some of the old terminology and just bringing it up to date. So unless somebody has any particular questions, it's all there, it's all highlighted. Most of it is, like I said, it's minor things that we just kind of tweaked a little bit.
Thank you. Any further discussion regarding the recommended changes to the bylaws?
Nothing further.
All right.
I think we may have a motion to discuss. We might need a motion to approve.
Oh, I apologize. I thought the motion was for both, was to discuss, amend, and approve.
I'm sorry, I'll amend my motion to discuss, amend, and approve.
All right.
Does the second accept the amendment? Thank you. All right, any further discussion? All right, all those in favor of approving the updated bylaws as presented, please say aye.
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 Thank you. Any opposed, say nay. Any abstention? All right, updated bylaws are approved. Thank you very much. Next, agenda items to be considered for the next meeting. So if there are any items that you would like added to the next meeting, please make sure that you send them to either myself or Shelley. Call to the public. Summary of current events. I won't go through all of these. I do see Dr. Walter has added the Advanced Hazmat Life Support is holding a virtual conference that's listed with the link to that in the chat box if you're interested. I think most conferences and trainings are moving to virtual right now, so hopefully that will be of use to people. We'll continue to kind of include them as they become available. Our next meeting is scheduled for January 21st at 12 o'clock. Location to be determined. We will definitely have a virtual option, and as we get closer to the date, we'll know whether it'll be virtual only like this meeting. Can I get a motion to adjourn?
Motion to adjourn, Maytem.
Thank you. Second?
Second, Walter.
Thank you very much. All right, meeting is adjourned. Thank you very much. I really appreciate it.
Thank you, everybody. Stay safe.
Thank you, everybody.